Sorry for the delay. On behalf of SIMSOG, I extend a warm welcome to What Went Wrong, a case-based workshop series on ethics and medico-legal perspectives in OBGYN. So, Society of Indian Medical Students of Obstetrics and Gynecology, SIMSOG, is committed to fostering interest in OBGYN through advocacy, academic discussions, and leadership opportunities since its inception on Women's Day, March 8, 2024. It has grown over 2,500 medical students across India. Now, I would like to invite our SIMSOG advocacy team to quickly introduce themselves. Karuna, are you there?
Yes. Hi. I'm Karuna. I'm the co-director of advocacy at SIMSOG. Nice to meet you all.
Naisa, are you there?
Hi, I'm Samriddhi.
Yeah, okay. Please continue.
I'm the AO of advocacy.
Yes, thank you, team. So, before we begin, let's take a moment to introduce the event itself. So, What Went Wrong? It is a 3-day case-based workshop series that explores the ethical, medico-legal, and clinical dilemmas which are encountered in the reproductive healthcare. So, as we set our stage today for today's workshop, it is important to highlight the core focus of this session, which is understanding the core ethical principles in obstetrics and gynecology, the role of informed consent in antenatal care and related procedures, and the ethical duty of clinicians in disclosing the prenatal findings. So, through today's discussions, we aim to reflect on how these ethical foundations guide real-world decision-making in maternity care, ensure respect for patient autonomy, and strengthen trust and transparency between the patients and healthcare providers. So we now move on to the main segment of today's workshop, which is the case-based discussion. The participants will be divided into 2 groups for this session, with each group receiving different case scenario for the discussion. So you will have 10 minutes to deliberate within your groups and analyze the ethical and clinical dimensions and prepare the collective responses. So after the group discussions, each team will present their findings to our speaker, highlighting key ethical issues, dilemmas, and the potential resolutions which are identified during this breakout discussions. Following these presentations, our distinguished speakers will share their insights and reflections on each case, offering both clinical and ethical perspectives that bridge the real-world practice and evolving medical ethics. So each case-based discussion, including the group deliberation, the presentation, and the expert commentary, will take about 40 minutes in total for each topic. So if you have any queries regarding this event format or the flow of the session, please feel free to reach to us. We'll be happy to clarify them before we proceed on with the group discussions. Have everyone understood the format regarding the event?
Yeah.
Yeah, okay then. So we now encourage everyone to engage actively and then approach the discussion with empathy and openness. We now request all the participants to kindly proceed to their assigned breakout rooms for the case-based discussion on the topic core ethical principles in obstetrics and gynecology.
Hi, I'm Karuna. I just want to interject because this is the first session. We shall have a discussion here first and then move on to the breakout rooms. So you will be sent to the breakout rooms in about 10 minutes. So till that we shall discuss. And just to sort of warm things up, because as I said, as Divya has added, the whole 3-day event is going to be very interactive. So to set things off, we could start with discussion. So if you guys would like to keep your cameras on, that would be great as well. Because right now I'm just looking at icons and then I see a minion icon. So you know, it'll just be better if you guys could keep your camera on. If you cannot, no worries. Hi. Yeah. Before we begin, right? So I am audible, right? You guys can see, hear me, and everything. Okay. So as I said, as a warm up, we have four things. Every time you talk about ethics, there are a couple of things that sort of keeps coming up. One is you have ethics, you have morals, you have laws, you have rules, right? So I would just, as I said again, this is an interactive session. I would really love everybody here to actively engage in the session. So these four words, I would like anybody from the audience to maybe define ethics for me, and then we could move on to the other three words and then continue that way. Whatever you understand of it, you don't have to Google it, you don't have to use AI, don't chat GPT. Just say whatever you understand of the word. Because at the end, see, if you're hesitating here, the next 3 days are just going to be
Can I
silence because
answer?
the whole event. Yes, sure,
So, I'm Vrinda Sarkar from JNMC Wardha, and I'm a first year MBBS student. First, I'll introduce myself. So, by ethics, I mean that the code of conduct a doctor has towards the patient, the way he interacts with him, with all the, the code of conduct he has towards the patient is the ethics. The
great.
guidelines there are for the ethics. So,
Okay,
I'll end up with this.
thank you for sharing.
Thank you,
Uh,
ma'am.
Anybody else wants to add on ethics? I think that was pretty comprehensive one-liner. Anybody else wants to add anything?
I don't know, not ethics, but maybe morality. Like, I'll
Sure.
just go.
Models.
First,
Yeah,
give a
yeah.
small intro. My name is Sai. I'm a final year medical student at GMC Kadalur. Uh, Morality is just like what is accepted, like good behavior, bad behavior, generally speaking. Like, it's not a very defined thing. You just go there and you just know what's moral. Like we always tell our colleagues, no, it's not right, it's not wrong. Do what's right. It's just not said. At least ethics is somewhat defined, I would say, but
Right.
morality isn't that defined, and everyone's understanding is a bit different. Yeah, I feel that ethics at least can be communicated easily, whereas I think morality, I think it needs to be understood rather than being communicated, is what I understand. Maybe I'm wrong. Please feel to correct.
Sure. Does anybody want to add on to what he said?
So, am I audible?
Yes, you are.
So, my name is Harish. I'm a post intern from Government Civil Medical College. So, ethics is actually one of the branches of philosophy, to be uh, precise. Like, philosophy is seven branches, and ethics is one of it. And ethics is where we learn what is correct and what is wrong. So, and since it being a branch of philosophy, I guess it does not always have the right answers of what is correct to one person might be wrong to another person. So I think medical ethics means in the framework of the clinical and the healthcare system, whatever is done to a patient, uh, starting from a research work or patient care, everything. So whether we do it in the correct way or the wrong way. So that is what is ethics in my opinion.
So are we reaching a sense of ethics could be more objective and morals be more subjective? Is that the consensus we are reaching at? Would you say?
No, in my opinion, even ethics is subjective, but law can make ethics a bit objective. That's what I think. Like, uh, it's always like in OBG, for example, we have abortion.
Right.
We- So that is an ethical, personal question. But a law can make it objective in how many weeks
Objective.
we can do, in what conditions we can do, all that.
Sure. Thank you for sharing. Um, we could, so we've done ethics and morals so far. If we could have more people on the call, uh, give us their definition of laws and rules. What do you understand about laws? What do you understand about rules? Yes, Abhinav.
Hi, am I audible?
Yes.
Hello everyone. I am Abhinav from Shri Ramachandra Porur. Uh, if ethics is more subjective, then laws and rules are more objective. What I understand is laws and rules, as Haris previously mentioned, they are more like the foundation. Ethics can be interpreted different by different people, but for a standard guideline, a standard operating procedure, if you will, we look forward to laws and rules so that everyone can come to a consensus as to what should be done, like a basis, if you will.
Okay. Thank you for sharing. Does anybody else have any other thoughts about this? Then we could talk about like certain examples and um, where do you think that would fit? Sort of what you would apply to it amongst these four words, and then we could do the breakout rooms. Yeah. Does anybody else have anything to share? Also, is there a bit of background noise? I have kids playing around, so is it annoying?
No, no, it's okay.
Okay, sure. Does anybody else have anything to share? Okay, seeing as there are none, we shall move on. So I'll give you some cases. Okay, like you will discuss it much more in detail, but just for now, say you have in your hospitals you have consent forms, right? Would you call that ethical duty? Would you call that a rule? Would you call that the law? How would you frame that? It's very easy. So low hanging, just um, whatever you guys think of it.
Uh, can I?
Yep.
Yeah.
Yep.
Actually, I think it's more of a rule. Like whenever we step into the clinic for the first time, the first time we step in, we never understand the concepts of concern. Okay, we just go in and directly barge and just start examining. Okay, I'm not gonna lie that okay, I just went in, asked the consent, wished the patient how are you and all that. It was such like good clinicians who like came up to us and be like, okay, see, she's a mother, a young one, very scared. Just go her, just talk to her, build a rapport, and then ask for things. So when I came into medicine, maybe I'm not as smart as the others, but I did not understand the concept of consent at all. Like I'll be very honest with you, I did not find like the need to explain them. My understanding was they know they're having something wrong, right? So they know that they're coming into the hospital. But then when you step in and start understanding the nuance in that, in emergency cases, it can vary. Them coming to hospitals might mean that it's implicit. But there are certain cases where certain procedures are not necessarily emergency, can be done as electives. It's only then I realized, okay, you need to explain the risks and the benefits. The moment you keep a knife, it comes with the certain risk factors. It's not the competency of a surgeon or the person who's doing it, right? So, and it's only then you start understanding, okay, you have to explain. And curiously, like you also learn like a bit of regional lingo for everything. It has to be in a regional. I did not understand like how to say like colon in Tamil, like despite being the Tamil guy. Okay, I have to go and explain that, okay, there can be something like this. உங்களுக்கு பிரச்சனை உள்ளதா உள்ளது and all that. And it was quite an exercise. I learned a lot personally, and initially you have to be very calm and composed about it as well. So initially I found it very tedious because the moment you go and explain them, and at the moment they read such a big thing, they just first say no straight away. So I thought like, okay, it's a bit of a hindrance. Should we explain everything? That was my concern. So it's more of a rule, actually. So cut the long story short, it's more of a rule, in my opinion. And it's only after, I grew up, I understood that, okay, like we need to explain them. So I think that's my view. People might correct it, like if I'm wrong. Thank you.
Yeah. Does anybody else have anything to add? Because
May I?
one exam, yeah, sure, go on, Abhinav.
I think it's a bit of both. Like you have the spectrum of like implied to the max of written consent. So implied is the patient knows that they have a problem, they come in, but it's in your best judgment to be like, I am going to examine you, I am going to take your pulse rate or whatever. So it's in your being courteous, I suppose, being a good person and being like, and don't just directly jam and do palpation, do something like that. But rather, on the other hand, written consent is like a written format, more of, you know, a solid form of info saying that so and so. That is more of a rule in my understanding.
Just one incident, as you said, you just like jump in and sort of start examining. I remember one incident where this patient was so done that people were doing that. He put his blanket on top of him and he just stood there for like 15 minutes. So yes, another thing that comes into play when you say that you have to sort of inform them about everything that you're doing is, do we have the time? Like now we do, because we're all pretty much students, right? We're sort of learning um, as you go. But then how, at what point does it, at what, because you don't see your attendings do it, right? Because so at what point does that transition sort of occur? And should that transition even be occurring? What do you guys think? Yes, you may speak first.
Uh, The thing is, like, I think, I've heard a lot of PGs say it, like, just like not say it implicitly, but while they're, reeling in, I mean, in bringing in the patient for like operation and all, consent vaangyacha, like, have you got the consent? It's more of legal thing, life becomes very hectic, I feel, in post graduation. And internship as well. Like you being in the final year, you just ask the PGs, I need this case, I need that case, can I see that? That's an exam case. That's not a statement you can, when someone shows a case with multiple complications, you have the luxury of saying, like, oh, is that an exam case? So I think that quote unquote exam case will go away, as we move forward. And my understanding is no patient who comes to your clinic, let's say in future, is an exam case, right? So I think, consent is more, I would say, like given importance in private practice. In government hospitals, your priority is to flush out patients because you're having such, inadequacy of resources, and basically you sort of triage like, okay, does she need this or does she really need this? Whereas in private, it's about dedicated care. And unfortunately, not many people can afford. That's the truth. A lot of government patients we see, they're only here because the treatment is free or, let's say, very affordable. So I think it's at that point when you're seeing hundreds and hundreds of patients a day. It's a very human thing to happen, I feel. Maybe if something, it feels very mechanical. And if that can be allocated to someone, I would say it's much better. There are hospitals abroad and even in like transplant units in some hospitals, they have communicators, dedicated communicators who go and talk to patients. They do that job. Here, it sort of becomes like everything is your work. So you sort of like categorize things as like, okay, this is like clinical, this is more like scut work, and you just want to do away with it. That's what I feel. Like a lot of PGs, like they're really nice people, like genuinely nice people who want to do something. But the moment like they're overwhelmed with so much work, it's going to be like, hey, you do this. Like it just becomes sort of a formality. I feel so. It's not like transition. We just push people into that. People never transition. I would say like nobody wants to be like, I don't want to be rude to a patient. Sometimes we just overwhelmed, and not we, like the PGs. I've seen like they're my teachers. A lot of PGs teach me. That's what I personally feel. We just push them to the extreme, and we just it's bound to happen. I feel something needs to change, or some third person with skill has to be brought into this so that is reduced. Is my understanding actually.
Very well said. You sort of like also gave a solution. I was going with, over the next 3 days, that's something that you'd understand how these things come into play, but then you also eventually did give a solution. So very well said. I see Vrinda also wanted to say something. Did you want to say something? Do you want to add something?
No, no, I didn't. I think it happened by mistake. Okay.
Okay, cool, cool. Does anybody else have to add anything and then we can break? Hello,
Hello,
am
hello.
I audible?
Hello, ma'am. Yes, you're audible.
Hi. Yes. So I was in one of the meetings and the discussion was intense, and then we sort of had kept it for 10 minutes for the first session. So we can pick it up. We shall pick it up after Dr. Animesh's session. Would that work for everybody? Because Divya, when is Sir joining? Okay,
You're
so
not
Sir is
audible.
here. Actually, Divya, I think Sir is here. He's just joined the meeting, so I think
Okay.
it all
Yeah,
works out
yeah,
very
it is
well.
fine. Yes.
Yeah, yeah. So we could start with introduction and then progress that. Okay. And then we'll pick up this topic again after that. Cool.
Okay. Yeah, yeah, sure.
Thank you.
And now it is my privilege to introduce our distinguished speaker, Dr. Animesh Jain, Professor of Community Medicine at Kasturba Medical College, Mangalore, and a distinguished expert in medical education, bioethics, and public health research. He has extensive experience mentoring students, guiding research, and contributing to national and international ethical issues and educational initiatives in medicine. So we are truly honored to have you with us today, sir, and we look forward to your insights on this important topic.
Thank you. Good evening.
Good evening,
So
sir.
now,
Good evening, sir.
And good evening.
Good evening, sir.
Good evening, sir.
Evening.
we are now yet to have the breakout room discussion for your topic, sir, informed consent in antenatal care and procedures.
Okay. So how do we go about, like, they are going to be one by one discussing it, or how exactly they'll be presenting it?
Um, like the participants will be split into breakout rooms, sir, like three different groups.
Understood.
So like in each group, they'll be discussing that particular case and then they'll be presenting the findings, sir.
Right. That I understood. So are they already in breakout rooms, or have they come back, or what exactly?
No, so they have just we've just like we were going through the day one session, but yes, we need to. They have to discuss on the day two cases as like, the topic two cases.
Okay.
So
Karuna,
I believe, yes, so I believe the PDF has been shared regarding all the cases. So the participants will now go into the breakout rooms for about 10 minutes. We'll set the timer, discuss whatever they find, their thoughts, and then they'll come back and then we can begin the session. So till that time, if you could maybe go through the PDF and stuff.
Yes, I had gone through two cases. Third case also I had to look, and so I'm just doing that. I will do that.
Yes, sir. So
Because I couldn't go through it completely, but because I also came only after 5:30, 5:45, so no problem. But I've gone through most of them. I'll just have a look. No problem.
Yes, sir. So we'll set a timer for 10 minutes and then just one case will be discussed this time. You will be split into 3 rooms for 10 minutes. Our team will present one case to you. You may continue discussing as you are, and then we can get back. Does that work for everybody?
So which case are we discussing?
So each room will discuss one case. So
Right.
when they come back and present all their findings, we shall talk about each case individually.
Right. Okay.
So I invite the participants in breakout room 1 to present your findings of the particular case, like which we have received. Or we can go ahead with cases 2 and 3, breakout rooms 2 and 3, who the participants who have discussed. It can present your findings now. Yes, please continue.
Good evening, sir. This is Sai, final year MBBS from GMC Cuddalore. I'll just try and briefly describe the case that was given to us. So this was a case where the female patient was having endometriosis, and the doctor said that had the consent for DNC. And what happened was in the later stage, he saw extreme aggressions, and he did a TAH and BSO, bilateral salpingo-oophorectomy for this patient. And the patient did file a complaint, and the doctor's argument was that this comes under implied consent. And we feel that it's not implied consent. That was the consensus that at least our breakout room had in some way or the other. Thank you.
Okay. So are you talking about that Samira Kohli case? Yeah.
Yes, sir. Yes, sir.
Right. So this is for the benefit of the others also, the other groups. So you can see that this was a lady who was 44-year-old, and she was admitted with irregular menstrual bleeding. And initially, the idea was to do a diagnostic. I'm stressing deliberately on that diagnostic DNC to see what is the cause. However, during the procedure, the surgeon found that there were fibroids and endometriosis, and then decided to go ahead and do a total hysterectomy with bilateral salpingo-oophorectomy, which it's something which is maybe probably medically like there was an indication, but there was no consent taken from the patient, right? You can see that the doctor did not take without obtaining I'm reading out from the screen, without obtaining specific fresh consent from the patient or her attendants. Neither was the patient. We can say that patient was on the operation table or whatever, was not in her senses, and was probably anesthetized or whatever. But there was nothing informed to the attendants, and the doctor justified this as an act of implied consent, which was in the interest of the patient. See, the whole thing about consent is that we have to remember that there is something known as autonomy. That's a basic principle. So autonomy has to be given to the patient to decide. We can have a role to explain things, to probably clarify things, but ultimately the decision should be the patient's and the patient parties. So that's something which is very, very important that we have to remember. We cannot act on behalf of somebody else. So we have to give them the right to decide for themselves. Okay. And this obviously went to the court, and then the court upheld that this was not justified and things like that. Now, also remember, what is done was not an emergency procedure. This was not something which was life-saving. It could have very well waited. It's not that if it was not done at that time itself, that same time when the diagnostic DNC was being performed, anything would have happened. So this is the reason why it is. And what also is important is that when we do certain things like this, we have to see to it that the entire thing is informed. Even for the diagnostic, if we say that, okay, we could have said that, in diagnostic, if we find something, and this is a kind of that if we find something like this, we might have to go on for something else, additional procedure. There has to be a justification, and that has to be understood by the person concerned. So that did not happen in this case, and that's why this is a case which is, it's like, what we call as paternalism, medical paternalism. That means the doctor says that I know the best and I decide for the patient. Now that is something which is not acceptable, and usually, as I said, only in cases where we can have a clear-cut thing that this will be a life-saving procedure or it was emergency, then only. Am I audible?
Yes, sir.
Yes, you are.
Okay, because I see my video seems to be frozen, at least to me. All right. Yeah. So that's what I was telling you. So basically, that's one of the things. And then if you look at it, you might say that, okay, when can we decide on behalf of the patient or emergency? So even in such situations, if there is a person who's there, if the person is on the table and then you cannot take the consent of the person and it's an emergency procedure, life-saving, at least take the patient's whoever relatives, legal or authorized representative, or say maybe a kith or kin, whoever is available, keep them informed and give them the right to decide. So that is something which has to be done. Okay, so that is something which has been upheld as well in the courts, and that has to be done. Okay, and another thing, very importantly, we need to understand and we need to give importance to the communication, because many times these are the problems which arise because of the communication. So there was no communication which happened between the doctor and the patient, and that's something which should have happened. And another thing, some time back, I mean, I don't remember when exactly, but Supreme Court had ruled that we cannot have a blanket consent. Blanket consent means it's an overall overarching consent where you say that whatever it is, like it can be done to me or whatever interest or the best interest, or I'm giving my consent for anything and everything. That's not, now it has to be very specific. So it has to be like, I'm doing this, this is the reason, this is what is the indication. If at all something happens or something, these are the possible or likely offshoots or complications, or say procedures which may be warranted if this happens. Again, within the reasonable amount of say complications to be thought, and of course not to scare the patient at all. So these are some things which have to be done. Okay. And as I said, if the patient is not in condition, it has to be explained to the patient party. So that has to be, and only minor things can be done. We cannot say that, you know, we will do a major intervention. And in this case, the nothing less than hysterectomy and salpingorectomy has been done, which is like removal of her reproductive organs. So we cannot do that. It's total violation of her autonomy. That cannot be done. So this has to be like explained, and then her consent has to be taken. Definitely. Okay. So this is something which has to be borne in mind, and which did not happen in this case. Any questions on this? What about implied consent? We can say that she gave a consent and then she was already on the table, and so it is implied. Can we say that? Is it implied consent?
I mean, the word implied consent implies that it's only for minor procedures, not even for procedures.
Right. So yeah. So implied consent doesn't apply to this case because it's a huge thing. You know, imagine somebody's organ is like, and it's a very important thing. So important organs, and we cannot do that. And you can imagine if we extend it further, or of course not in this case, but imagine somebody goes to the table and then we decide that we'll take harvest some organs, and then so it can be, that's what was the problem. Many times without people's knowledge, the kidneys and other things, those rackets were flourishing, right? So it cannot happen. And it is not at all legal. It's not ethical. Both the things are being violated. Okay, so because sometimes what happens is legal and ethical are different things. But here, both the things are wrong. So we have to remember that this cannot happen. And even if we say that we are going to say that, okay, this is beneficial for the patient. So there is, again, if you see the two principles, beneficence and autonomy, they are in conflict. But again, autonomy is very important, and beneficence, again, whose beneficence? Patient's beneficence. That is the benefit of the patient, or it is going to be good for patient. Now, patient also has to be party to it, and patient's party or patient's relative or whoever is there, that person has to be a party to it. I cannot decide on somebody else's body's functions or removal or something, right? So it has to be very specific consent. It should be informed to the person, and it should be, very importantly, it should be voluntary. So these are some things which have to be remembered. All right. Any other questions?
Sir? Yes. Good evening. I'm Karuna. I'm a third year medical student. So just for my understanding, when we say implied consent, what are the cases? Of course, not here, but what would be the situation where implied consent could work?
So see, certain things, when the patient comes to you, okay, you are in the OPD, the patient comes to you, gives the history, and you say that, okay, now I need to examine you, the general physical examination, blood pressure measurement, those things. Or even if you say that, okay, there's a couch, or there's a room, examination room, and why don't you step in there and then, okay, and depending on the gender, you will also have a female attendant if it's a female patient, because that's warranted and that's required, even from the perspective of safeguarding your interest tomorrow if there is a litigation or some other things happen. So those things where you are just doing that basic thing, again, in that, if you're planning to do something invasive, you will not be able to do that without taking a consent. So suppose I decide to do some procedure there, okay, or if I need to say do a FNAC, just for example. Now that's not an implied consent. I said that, okay, come on, I have to check you and all. But then you might say that, okay, I assume that the patient has agreed to it and that's why I'm doing the FNAC. No, you cannot do that. So certain things which are non-invasive, that's all is limited. The implied consent is only to certain things where it's non-invasive, and it is just going to be understood. And even there, it's good to tell them that, I'm going to measure your blood pressure, I'm going to do this, so make them understand that. You don't have to describe the entire procedure, because those important, these minor things are possible and they understand. Or for example, somebody goes, like if we go to a dentist. Now dentist says, okay, I need to examine, you need to so let me check. And a metallic thing which has a end which is hooked. So if the person uses that, that's understood. For that, I won't be signing a consent. But the moment I am going for a procedure, like suppose, or if he or she plans to extract, so that has to be more explicit consent. And many times they will take a written consent. They will, even if they are doing a local anesthesia and procedures under that, they will take a consent there, right?
Understood, sir. Thank you.
So which college are you from?
I'm from BGS Medical College. It's in Bangalore.
Okay. Which year did you say?
Third year.
Oh, okay. So I'm from community medicine, and I believe you must be in community medicine right
Yes,
now.
sir. Yes,
Yeah.
sir.
So you must be knowing Dr. Jayashree Singh.
Yes, sir. Yes, sir. My HOD. Yeah.
Yeah, she's a good friend of mine. So
She,
yeah. So BGS I have visited sometime back, and there's another BGS group institution now in Nagarur in Bangalore. And I
yes, sir.
visited.
The new one.
Yeah, so the HOD there and some other faculty are my friends as well. Anyway, just okay.
I guess one breakout room had case 3. So yeah, could anyone from that breakout room discuss about, like, present your findings here?
This is the case about that Indu Devi. Yeah, okay. Could you please project that case also? If somebody is presenting, it becomes easier. Yeah.
May I?
Yeah, please.
Yes.
Please go ahead.
Good evening, sir. This is Abhinav, a third year MBBS student, sir, from Sri Ramachandra Porur. So,
Porur.
as far as I understood, yes, sir.
Okay. Go ahead.
As far as I understand from the case, Indu Devi, woman, she finds out during an hospital visit, an examination, that she is pregnant, 13 weeks pregnant. But due to the fact that she has a history of HIV and a history of mental illness, she wishes to abort her kid. But the hospital or the administration citing identity issues, like we are not sure how to proceed for this, delay the abortion. So 20 weeks go. The gestation reaches 20 weeks, and now the family members or the representatives of the patient write a petition. But again, here the court states that since the pregnancy has passed this cutoff for legality issues, abortion is not possible. So here it's a clash between the patient's interest, who wishes for abortion due to her reasons, and the laws which are supposed to cater for the patient, due to being the wordings being very rigid, opposing her interest.
That's right. So see, one more thing is you didn't mention particularly, though I'm sure that you've all seen. Just scroll up a little, just for the initial part of the case. Just scroll up a bit more. The initial part, yeah. So you say Indu Devi is a woman who was rescued and housed in the rehabilitation center. You said that she presented to the hospital, right? But she was a woman who was being rescued and housed in a rehabilitation center, whatever, Shanti Kutir or something in Patna. Okay. And then it was found out that she's diagnosed to be pregnant. And this is 13 weeks plus 7 days, 6 days. So let's, for practical purposes, let's say it's for 14 weeks. Okay. Now, 14 weeks she has been diagnosed. And then she is also HIV positive and some mental disability. Now, the issue is that here she has HIV and she has got mental disability. And she's already under treatment by a neuropsychiatrist. However, the father supports her and the welfare center supports her, and she expresses her wish to terminate the pregnancy as per the MTP. Now, we all know that till some time back, I think till 2021, February or March, we had this MTP saying that up to 20 weeks we can terminate the pregnancy safely, right? Of course, it has been further amended, and we'll come to that in a bit. But this is what was the thing. And since it's 2017, obviously, that rule was up to 20 weeks. Now, for variety of delays, including technical, procedural, saying that, okay, we need a consent, and where she can give a valid consent, our identity issues, we cannot establish her identity, the timing and the medical board which has to be formed so that we can get an opinion of all the people and then, go ahead with this kind of a thing. So that was a delay. And the pregnancy progressed beyond 20 weeks, right? Can you just scroll down a little bit? Just a little bit. Yeah. No, yeah. So see, the pregnancy went beyond 20 weeks. As I said, the act, the MTP, that is Medical Termination of Pregnancy Act of 1971 in India, which was, instituted and then came into force in 1972 April. So it said that up to 20 weeks we can terminate the pregnancy, and beyond that it should not be, right? Because they said that it can pose risk to both fetus, mother, whatever. So court said that now it's beyond 20 weeks. They also saw the report of the psychiatry reports from the multidisciplinary medical board and also her HIV status. And they said that there are issues, and then there are risk factors, and the pregnancy is already gone beyond 20 weeks. So it's not safe to terminate the pregnancy because there are risks, and it can jeopardize her health condition as well. So this is diametrically, like if you see, there is one more case, you'll see that there is that's just opposite of this. So here in this case, the termination was not upheld by the Supreme, is it Supreme Court or what? Let me check straight. Okay, so the court said no, it cannot go ahead, and that's what happened. So now if you look at it, if you see, is it her mistake? No. She was an institution, she was in the custody, and the Patna High Court it is. So the court said that we cannot proceed. If you look at it, basically she and her parent and even the welfare house or welfare organization, they said that you can proceed, and they can do that. And almost about 6 weeks it was delayed. Now this is a lapse on the part of the infrastructure, the mechanism, the processes, and also from the medical board as well as from the hospital side, right? In such a case, 6 weeks of delay is quite a lot. And what we should do is we should try and see to it that these delays are avoided, because it can lead to such situations. Now, obviously, this was not something which they wanted to, and it will add to additional burdens. But of course, the court in its own wisdom, looking at multiple things, including the health status and the risks involved, said and ruled saying that no, the MTP should not be carried out, right? So again, Sometimes, though the autonomy would say that she must uh, go ahead and imply her wishes and her wishes should be respected, but uh, in this case, because she was vulnerable, because she had a condition, that is, she was HIV positive, there was also an issue of mental illness, and the pregnancy had progressed beyond 20 weeks. And with all the medical knowledge and the experts' opinion put together, this would have jeopardized her life. And remember, the state also has the duty to uphold the life of an individual. So that took precedence, and that's why her autonomy was kind of overruled. I hope you're understanding the scenario. Of course, we can debate about the procedural lapses and the delays and other things which could have probably led her to go ahead with the abortion, but that did not happen. And that can be an issue and that can be tackled. However, having said that, if you look at it, her autonomy did not get upheld. And then she also had issues of psychiatric illness, and the ability of the individual to consent can be challenged. The maternal risk and the fetal age also was not in her favor, and obviously she had HIV positive. So all these things actually played a part. What has happened in 2021 is that the MTP Act is expanded, and it has been amended to go ahead up to 24 weeks in certain category of people. Okay, so up to 24 weeks we can go ahead, and if at all there is a fetal risk, so it can go, like if there are fetal abnormalities, so there is no gestational limit of 24 weeks also. Okay, but again, there is no clarity on that. Okay, but 20 to 24 weeks, there are like see, up to 20 weeks it is proceeding like what it used to happen earlier, but beyond that, up to 24 weeks, we can have opinion of two registered medical practitioners, preferably the obs and gynecology experts, and these applies to minors, people who are differently able, mentally challenged, any of the humanitarian crisis, rape, incest, sexual assault, any kind of fetal malformation. So all these things, or even sometimes changes in the status of the woman from being married to, say, maybe divorced or something like that. So all that can be applied. So that's the change which has happened in the amendment in 2021. But if you have questions, you can ask me. I mean, I've tried to give you a picture, but again, I'm sure that there are certain other things which you may want to ask me. I can try and answer if I can. Yes, Raju?
So will the MTP be extended further? So is it a trend? Like, okay, earlier it was less and now it's 28. Is it a function
Not
of
28,
like
24. I said 24.
24? So is there a possibility that it will increase with increasing advent of healthcare?
Don't know. As of now, don't know. And we cannot wait for that to happen, and that's not something. But as I said, again, in fetal abnormalities, 24 weeks also doesn't apply, though there is no clarity, but we can go ahead even that. And then again, if medical board feels and there is concurrence of two or more people, and so it can, and of course with the what do you say, the patient's consent, we can go ahead. But as of now, there is nothing which suggests that. And see, even for this to happen, if you see 1971 Act got amended in 2021, almost 50 years. That's a long time, right? But again, if you look at it, we've been one of the progressive nations in that case. And in fact, if you know that one of the, big brothers is going retrograde in that, right? One of the nations which is supposed to be very progressive, in many of the states there, now the abortion laws are getting retrograde. I'm sure you know what I'm talking about.
Yes, sir.
Sir, I have a question.
Please, Harish.
Sir, regarding the duty of the state to protect the life of the women, and that is one reason why beyond 20 weeks the court said no in this case. So, but when the court or the legal system says no in such cases, what if the other women or even this women choose illegal uh, ways to abort their kid beyond 20 weeks? That is even more dangerous. Why not we, uh, allow it legally itself? Isn't that more dangerous?
I didn't get. I didn't understand. I understood that you're saying that, see, there is a duty of the state to protect the right, I mean, protect the life of women. That's what you said. Then you said that the court did not allow, and then she should look for the avenues legally for aborting. This is what I understood,
Yeah,
but I did not
they,
understand what are you trying to say. I'm sorry. Please clarify.
no, through illegal means. I
Oh, okay.
used to say about village side they do illegal abortions through.
See,
Uh,
see. That's what illegal is illegal. Whatever illegal, everything illegal is illegal. Okay, there is a right way, and there's a the thing else is not right. So we will not discuss that. Yes, I understand what you're trying to say. There is a possibility that this lady would have explored some illegal or some ways which are not really uh, acceptable and maybe not appropriate. But that's something which I think we should not really discuss. And another thing is, in this case, it would be really difficult because one, she is already in the rehabilitation center. She's already in the purview of the system. She's already gone to the court. And then definitely, if she goes and does something like that, she will be the one who will be pulled up. She will have to pay the penalty. Who knows, she may not even survive because she's gone for something which is not the right way to abort. So a lot of things are there, a lot of issues. And as I said, I don't think we should think of that illegal kind of a thing. I do understand you're trying to make a point because there is a possibility that people will resort to that, and why not encourage people to go legally and rather than go to some other quacks or whatever, and that will be in the interest of preserving the life and things like that. I do understand that, but having said that, see, we have to follow the law of the land, right? And law of the land always supersedes or precedes. So we have to remember that. And then in this case, this is something which will obviously be upheld. I mean, just deviating a little, if you see, there have been instances where there have been children with terminal illnesses and things like that, and parents have gone to the court and they have been denied that they should be given the right to perform euthanasia. In fact, if you remember, even Aruna Shanbag case, she was in coma for, I think, more than 2 decades or something. And then, of course, that has been a precedence now for the little amendment that we have in Euthanasia Act. But that's a long time. And in between twice or thrice, twice at least, if I remember, her well-wishers and people had gone to court demanding that there should be a euthanasia allowed, right? So again, it did not get approved by the court, including the Supreme Court, and that did not. So legally, that's not right. But I appreciate your thought process and the question that you raised. From Harish?
yeah, thank you, sir. Thank you.
So which college are you from, Harish?
Sir, I'm a post intern right now.
Oh,
I studied in Government Civil Medical College.
government?
Civil Medical College in Tamil Nadu,
Okay, where is it based?
near Madurai. Sir.
Okay, okay.
Aditya, are you gonna present the case too?
Yes. Am I audible?
Yes, you're audible.
So the case 2 was about Suchita Srivastava versus the Chandigarh administration, in which she
Can you
was
please, yeah, please project that. Yeah. Right.
So they now the administration considered that now with, as it is said within double quotes, we can understand, we can make a assumption that this was for the legality ki matlab ki वैसे for a legality they have mentioned कि she has a mild mental retardation to justify their means, and by that they are now the Chandigarh administration tried to force upon a termination of this pregnancy. Citing that she was, even though Suchita didn't want that pregnancy to be terminated, the High Court order was gave the in in favor of the Chandigarh administration, gave the ruling in favor of the Chandigarh administration. So she again challenged this ruling in Supreme Court, where the Supreme Court put a stay order upon the High Court's order, saying that it is the patient's wish that is paramount, and just by declaring someone mental retardation, that she is mentally retarded, you cannot deny her the rights. So and therefore they formed a board and an examination expert board to basically review the case, and it was come to the understanding that she was not of such a scenario she cannot make a decision on her own, and therefore her wishes were then accepted. But यहाँ पे अब there is a very huge miscarriage of justice, as we are not able, the administration at the level of the primary healthcare was not able to cater to the needs, and just because they thought कि ये गलत है, and just because of they now started imposing their thought process when Suchita could make a decision on her own.
Right.
Yes.
So what are the issues? Aditya, where are you from, Aditya?
Sir, I am a third year medical student from GMC Nagpur.
Oh, great. Okay, nice. A very good college, very old college, and lots of people have been there from that college at a very important positions. Go ahead,
Yes,
go ahead. Yeah.
sir. So the problem here lies that they didn't respect the patient's choice here. Again, the same case as before, that they didn't respect the choice that she was going forward with the case. She didn't consider the alleged sexual assault. She considered that to be a consensual sexual war, and therefore she wanted to keep the child. But again, now the court is now the administration, the government is trying to, an institution of government is trying to intervene in a case where they should not, and now they are which should not be done from a patient's point of view, because the patient is able to make her decision. She was able to consent for the sex. According to her, she was able to consent for the sex, and now therefore she is demanding to keep the child. But the High Court, as well as the local administration, as well as the High Court, is not able to properly address this, and therefore she had to go to the, and of course she would have had to face a lot of societal judgment and things which would have impacted her health much further.
Right. So this is again one of the landmark cases. Now you see the first sentence is Suchita Srivastav, a woman with mild mental retardation. What is the implication of that?
She's somehow, they are trying to project her that she is somehow not able to make decisions. She's not capable of making decisions on her own. She is suffering from any mild mental disorder, like she might be either depressed or might be having certain
No. Mild mental retardation does not necessarily mean depression or something. What is mild mental retardation? See, what you're saying is something of a mental illness, right? Retardation is when we are having a developmental condition, okay, which probably will be relating to the functioning or the behavior or something like that, okay, and not necessarily always it will be impairing the decision making. Okay, so I want you to distinguish between these two things. Mental retardation and mental illness, these are two different things. Okay, even the Mental Health Act talks about it in a different, mental illness is defined in the Mental Health Act, and mental health, mental illness can actually impair the informed consent and the ability of the person to consent. Okay, it could be schizophrenia, it could be anything, any depression, bipolar disorder, all these things will come under that. Okay, but retardation need not necessarily be the same. Okay, so that's the something which is, and again, very interestingly, because I did a little of look up earlier in the evening. So as per the law, mental retardation is not something which can come in the way of giving a consent which is valid. Now, if you remember, there should be a capacity to consent, voluntary consent and capacity to consent, right? Now, capacity to consent is to be established by, you know, say neurological as well as psychiatric examination. Now, retardation, mild especially, will not be the something which can impair that ability to give consent. Whereas if it is an illness, there is a possibility, and then there is a possibility that the person does not have a the capacity to consent, does not have a capacity to give a valid consent, and that becomes a legal issue. Okay, so that's why I wanted to draw this attention. Okay, now again, if you see, you also mentioned it, Chandigarh administration, that sentence, claiming it was in her best interest. Okay, now again, this is paternalistic, and in this case she can decide, and she is willing to decide, and she is wanting to. And then you also see the reference to the article 21. Okay, article 21 is the very important act where we, I mean, article 21 gives us the freedom, so freedom to do things, freedom to, do certain things, and so the right to life basically. Okay, so here again, that is being compromised. So there are very important things here. And again, if we look at it, nobody, including the state, can decide on somebody's behalf until unless, of course, I've told you earlier also, there are certain things, including where we are looking at a person's welfare as well as life-saving conditions. Okay, and in cases of disability also, the decision to continue or terminate a pregnancy will rest with the woman until and unless there is a incapacity, or, as I said, mental illness or something. And even mentally retarded does not come into the picture here. So she still has the constitutional right to her dignity, her bodily integrity, her privacy, everything, including the choice. And in fact, this judgment is one of the landmark judgments where, because it also gave us that reproductive choice is integral to the life of the woman and the liberty that she has, and she can exercise it. Okay, so this is a very, very important, and I'm happy that the organizers have chosen this case, but this is what I wanted to impress upon you. Okay, but however, having said that, please understand that in this case, there was a distinction made between mental retardation and mental illness. Okay, and that is why the Supreme Court pitched in and said that, this is not equal to, mental retardation is not equal to mental illness, and she has the right to retain her reproductive rights and decide on her own behalf, and capacity to consent is already there. So it cannot be like contradicting with her right to life, and the Article 21 came into picture. Okay, and consequently, the state has no right to decide on her behalf or authorize a termination, and she is the one who has to decide, and her choice has to be respected. And that is why it is a landmark. Right?
Yes, sir.
So see, what happens is sometimes what it appears and what, see, that's why I said this is a very, if you see the other case that Hindu Sina or something, the Patna one, there is a total difference here. Here we are giving her the right to decide. And then in that case, since there were other conditions and all, so it was decided that no, and it will also jeopardize her life and the baby's life, so an HIV condition and mental, illness. So that's why it was not given that, that she should decide, and this is why these two are just opposite kind of a thing, and very interesting cases. Right?
So while we were split into the breakout rooms, this case got missed actually. So we two rooms had discussed case 3, which is why Aditya had presented case 2. So if anybody else on the meeting has anything to share about this case, any questions as well?
If you have to share some additional points which we might not have touched upon, please do that. If you have any questions to ask or maybe clarify, please do that. This is a forum.
Sir,
Yes.
good evening, sir.
Yes. Good.
Sir, I want to thank you for taking up this because it has been taught that a 18-year-old person is able to give consent for himself or herself, and if she or he is not mentally healthy, then his or her legal guardian can give the consent. But in this case, you have told us that in such a situation, the female could decide. Then I was like, okay, so I was thinking something else, that how things really work.
So interestingly, that's what. See, a lot of things are there, and I'll tell you, whatever we may say, I mean, our country, of course, that's beside the thing, and you should not take it in any way or politically. But I'll tell you, I have, and whatever experience I have, like I've had lots of experience, and I've seen many places within India and many colleges as well as abroad I've visited. So I'll tell you, we are very progressive when it comes to many things. Our problem is corruption, population, and implementation. Okay. So we don't implement things. If you see, we have lots of rules, lots of regulations, but we are weak at implementing it properly. Okay. Coming to what you said, yes, interestingly, we give lots of rights to women. Many times they themselves are not aware, or they are not upheld by other people, and then they are suppressed and things like that happen. But that's where the this kind of programs, awareness, education, and creating a society which will be conducive, which will also be supportive, that's where it matters. So now, if you guys are sensitized and you can pass on this kind of information to your friends, your colleagues, your peers, at least some people will be sensitized, they'll be knowing and they'll be aware, right? Similarly, we also need to give this women empowerment and things like that in actual sense rather than just the lip service, where people can actually do. And if you see, these are, I mean, I'm very sure that you'll believe that these were not some super, rich or say super empowered women who took up these cases and they went to the judiciary. So somebody or the other, or maybe some NGO or somebody supported them, and that's what these are landmark cases. So this has happened. So that's another thing which we should try and do, because I always believe that we need to also stand up sometimes for certain things which we feel are right. I'm not sure whether I've answered your question or whether I've further complicated or confused. In that case, you can always ask me again, Kushi. Okay, you're welcome to. But I just shared
No,
some
no,
of
sir,
these
thank
thoughts
you.
which came to my mind.
Sir, I got
Yeah,
it a better answer. I got it better.
right. And where
Thank
are
you,
you
sir.
from? Which institute are you from, Kushi?
Sir, I'm from GSMCH, Rajpura, Punjab.
Okay, okay, that's nice. So we have representation from north, south, west. I don't know if I've not come across anybody from east. And I don't know, Raju, where are you from? I forgot to ask you.
Sir, I'm also based from southern side, sir. It's GMC Kadalur. It's near
Yeah,
Pondicherry, so we're also from south.
yeah. Okay, that's okay. No, so we have representation from southern states. We have representation from west. I heard somebody from GMC Nagpur. I have like already heard somebody from northern India, as well as I don't know if we have somebody from east or central India. I mean, Nagpur can be considered actually central India, but yeah, good. Any other questions, any other thoughts, any other things that you want to share, please feel free. And let me tell you, I'm not a know-all. I'm just telling you what I could think or what, but it's not necessary that, I know everything. And in that case, I will upfront tell you and I'll obviously do my homework and get back.
Um, Guys, do you have any questions? If we have them, we can discuss about it now, or else we can wrap up Dr. Animesh's session now. Yeah. Okay then. So thank you, Dr. Animesh, for your valuable insights and your perspectives for this session and to guide you through this session, sir. Thank you so much.
Thank you so much. It's been a pleasure and wish you all the best to SIMSOG as well as, I don't know how you pronounce it. I hope SIMSOG or SIMSOG, whatever. And also to all the participants. Do well. And please remember, do the right thing wherever you are. May I take leave?
Yes, sir. Yes.
Thank you so much.
Thank you, sir.
Thank you, sir. So now we request all the participants to, kindly move to their breakout rooms for the cases on ethical duty based on prenatal findings.
Am I audible?
Yes, you're
Yes, ma'am.
audible.
Okay, cool. So right now, given the time, would you guys prefer if we sort of continued the case we were discussing before Dr. Animesh's session?
Like the case that we have right now, is it like very different from the other cases, or is it based upon the same scenarios that we already had? Like,
I don't get what you mean exactly.
no, is
Uh,
the case you had, like you have right
right.
now, like is
Okay.
it like very different from the other circumstances, or is it more or less based upon the same set of circumstances?
The topic of this time, right? So we could, I would suggest we do the previous cases itself because we were sort of discussing it and it is going well. And then we could sort of come back to this.
Yeah, sure.
So if we could have Aditya, you were presenting the two cases, right? If you could just like project that and we could talk about that.
Oh, the one in the starting, no, no?
Yeah, yeah, that.
Give me a second. Is the screen visible?
Yeah, it's visible.
Yeah. This was the first case about Poonam Sharma versus the Union of India. And as already discussed, Poonam Sharma was pregnant beyond the 24-week limit under the MTP Act, petitioned the Supreme Court to permit termination, citing deteriorating mental health and prior medical complication. The government opposed, referring to fetal viability and statutory restrictions. The medical board at AIMS offered divided opinion, but petitioner insisted on her right to decide. So I'll again open the session to discuss what is the bioethic principle that is being the main being the basis forming the basis of this case, and how what conflict did it give rise to, and how would you have been dealing with such a problem? So anyone? Abhinav?
Oh, yeah, I'm thinking about it. Sorry about that.
Okay, so the
Bhumika?
point of these initial cases, we have like 5 cases, okay? The point of these initial cases was to, I'm sure after Dr. Animesh's session as well, we understand that there are 4 pillars of medical ethics. Here, we would like the participants to sort of tell which main pillar applies here, and then we could take it from there.
Patient's autonomy, right?
Yes, that's right.
Okay, could you elaborate?
I mean, at least as far as I know, it is ruled that the woman has the right to decide what is happening to her, whatever procedures is being done, or at least in this specific case. So, autonomy is basically she able to speak for herself, not letting anyone else speak on behalf of her. I'm not finding the words to put it, so sorry about that.
She is freely able to express her views on how she wants to be treated, on the choice of the treatment, and she would like that her choice is respected, not
Yes, yes, exactly.
shot down.
I guess beneficence that the court has decided to act in the best interest of the patient, overruling the autonomy, because beyond 24 weeks it is dangerous to get an abortion. That should be the reason.
But isn't beneficence something that's between the doctor and the patient, the treating physician and the patient? Or is it
It, uh,
between the state and
yes,
the patient?
actually, it is between the doctor and the patient.
Should
I
we
mean,
move
the
on?
slide also says the government opposed due to statutory restrictions. Like it is confined due to the laws under which the court functions. So it's more of autonomy being, constrained due to rigid wordings of law, at least.
Yes. So, anybody else? If not, we can move to the next case. Anybody?
Okay, so
Uh,
yes, if somebody else wants to go, please go ahead.
Yeah, I just feel that this is more like the state, also has the obligation to protect the life, right? Like the case never mentions the circumstances exactly. So she might have been really sick. That's why I feel the board was also divided. So I think we should also think from a medical perspective as well. So the state also has the obligation that it should protect. So maybe yes, rigid wordings of law, but also, the state has to protect the life. So maybe I think it depends on case to case basis. That's what I feel.
Actually, I agree with you because once it's beyond 24 weeks or it's about 24 weeks, it's like special circumstances if the marriage has been broken or she has been raped, and now it has been detected that some serious complication is about to happen in the child or something. If there is not such kind of situation, then in such cases, government always and should try to protect the life which is about to come and of the mother too if it is not that complicated. I agree with you.
So, anybody else? I was thinking for the next case, let's do a role play. One of you can be the prosecutor, one of you can be the defense, and one can be the law, the judge. So that would be fun. Let's move.
Sure. If anybody from the people that haven't spoken today could volunteer, that'd be great. Or we could also pick out people. We have been picking out people, but we've been ghosted from your end. But if you want to volunteer, that'd be great. I see Shraddha hasn't spoken so far, and Hafsa, I don't think I've heard you speak as well. So would you guys like to volunteer?
You can even be the journalist, the
Yeah.
pokey one. Nosy one.
Yeah, so we have the second case, right? Okay.
Yes.
Vrinda,
Okay.
do you want to go?
Yeah, I can. It's a
Sure.
role play, right?
Yes. And I believe another
Okay.
person spoke as well before I cut them off. So if you want to go, go for it.
Like, what should I do? Like, how should I start it?
So you can be anything you want. And Sai or Abhinav or Harish, what do you want to become? The state of Maharashtra or Supreme Court? Anyone? We have two positions open.
You can be Supreme
Um,
Court for the next 5 minutes.
okay,
Why?
I'll be the Supreme Court.
Okay, so now we need a defense lawyer from state of Maharashtra.
Defense lawyer defending the survivor, right? I'll do that.
Okay, okay. So we can start the case. So the prosecutor should begin.
Okay.
Brinda.
Yeah.
Yeah, yeah, yeah. So I'll make it like a role play.
Yes, yes. Any way you like.
Okay. Yeah, yeah. So I'm a 14-year-old girl who has just survived her life-threatening kind of a rape, and I am 28 weeks pregnant, and I really want to terminate this.
The court totally empathizes with you, but rules are rules, and we have a limit on this. Where the court would like to direct it to the medical board to evaluate on the special circumstances that you are in, and I'll direct it to the medical board.
Okay.
As the uh, defense lawyer, I feel that in our country we have common law. So I believe law is little flexible and it can be considered case by case. And in this case, she is a 14-year-old rape survivor. She had gone through a lot, and I don't feel uh, comfortable discussing whether abortion should be an option for her. I believe it should be the option for her. I plead the court to make an exception in this case.
Okay. Thank you, sir.
Do we
I think we're
have
done with this.
Yes, the medical board decides to rule in the favor of abortion because of the such circumstances. Now, this is the recommendation from the medical board, and now it's upon to the court to decide upon it.
uh, considering the special circumstances in which the aforementioned Jade Doe has presented, and also hearing from the defense lawyer and the board, which suggests that continuing the pregnancy might endanger the health of the person who has appealed, the state has the life also has the right to protect. So I think the Supreme Court will order the termination of the pregnancy and ensure the well-being and the rehabilitation of the victim who was raped.
Okay.
That's what I
Thank you,
would do
sir.
if I'm Supreme Court.
Yeah.
Okay, it's a
Uh,
win-win situation for everybody. So
it is. It is.
Based
congratulations. So
We have a okay. So based on the four pillars of medical ethics, where would you guys place this?
I think autonomy.
Okay. Autonomy, how? Could you justify it?
Because the patient's wish has been, looked after, that what she wants, not what the rule is, which is 24 weeks, and after that you cannot terminate a pregnancy.
Okay. So anybody has any other opinions? Does anybody have any other
This could
opinions?
also be a take on justice, right? The fourth pillar, because the
Okay.
board makes sure there's a you know, medical representative to make sure that this individual is being catered to, her voice is being heard, proper due respect is being given to her concern.
Okay.
But it's not justice, within the frames of medical ethics. Uh, it means to treat everyone equally and not, that is what the definition of justice is, right? In medical ethics.
Oh, I misunderstood it, I guess. Sorry about that.
My understanding of this is very simple. My understanding of this is that the court would have approached it as it has the right to protect a person. The state has the right to protect the person. So the reason why medical board was involved here is not to evaluate the law. The court knows the laws are rigid. The court knows the definitions. The court intervened because these were special circumstances and the health of the mother was deteriorating. Right, the health of the person was deteriorating. So that is the main concern here. They did not approach it via legal issues. The reason why the medical board was, directed to look into this patient was because the patient mattered. The 14-year-old girl mattered. So I think it should be approached with in the lens of the state has the right to protect a life. So more than justice, more than equality, this is more of equity. Uh,
Yes, great point. Could you, for the benefit of our audience, talk about your understanding of equality, equity, justice?
I'll put it very briefly. Uh, When it comes to justice, we cannot say that one size fits all. Every circumstance is different. There are times when the court does take sides. In a polarized world, having that sense of rigidity, it helps. Oh, now we have laws. Oh, now we have this. Now we have that. But I think at the end of the day, humans are humans and circumstances are circumstances. So justice is when it's not about equality. It's not giving the same judgment for 100 cases because that's what the law says. It is about putting in that effort to make sure that everyone gets justice according to their terms. It is plainly that. Don't put a blanket over it and say that it's justice. It's done and dusted. No, not all cases are same. And that's my stance. No blanket justice. Justice differs. There is justice, but it differs.
Does anybody have anything else to add?
I would like to add something.
Yes.
Regarding equality, equity, and justice, there's like a famous diagram that I always remember. It's about three children trying to see a football match, but a big wall is opposing them. So these three kids are of differing heights. One is like really tall and can see over the wall. The other two are like shorter and are not able to see the match. So in regards of equality, everyone is given a box for them to step on. So the tall person has no qualms about it because he can already see it. Now the second person is also able to see, but still the third person is unable to see. The same sort of judgment is blanket applied to everyone. Equity is realizing that the shorter person needs more, intervention to make sure that they are able to enjoy the match. So they are given more boxes to stand on. Justice is basically removing the wall, finding the problem and trying to remove it rather than working around it. I guess that also is important here.
Can we
So,
move on?
yes, we could. So right now, as it stands, because we had a bit of time constraint, we because we had a bit of time constraint, we sort of have decided we could do the third session of today, which was supposed to be prenatal disclosing prenatal findings. We could move it to day 3 and club it along with topic 1. Would that work for everybody in the audience?
Yeah, it's okay. We can do that.
Okay, because it was a little bit of a hassle today. If that works, then if you guys have, we have 3 more cases. We could just quickly sort of go over them and wrap it up in the next 10 minutes. If you're okay with it, please raise your hands. Okay, so the next case, Aditya, would you like to, or if anybody, I think you've read the case. We've also discussed this in the breakout rooms before Dr. Animesh's session. So if you have anything to add about this, what pillar of medical ethics you think this is, what went wrong, you could talk about it, and then we shall continue. I would really appreciate if someone that hasn't spoken so far volunteers. Because while it's been a great discussion, it's also still, there are a couple of people that I can see who hasn't spoken so far. Okay, Aditya, would you like to present the case?
Yes.
Okay.
So, again, this is a case, Deep Nursing Home and another versus Manmeet Singh Mattewal and others, Supreme Court of India, New Delhi, judgment delivered September 2025. Charanpreet Kaur, 8 months pregnant, delivered a stillborn baby at deep nursing home. She developed massive postpartum hemorrhage and died hours later. Her husband alleged negligence in managing the emergency, citing delayed transfusion and lack of adequate facilities. The doctor contended the death resulted from an unpredictable amniotic embolism, fluid embolism. So now we need to discuss which of the bioethic principle is being यहाँ पे discussed, and the basis of the conflict and how do we deal with this conflict. Yes, I.
I think the court will definitely look into the treatment. So I think that's why doctors are advised to stick to a protocol. I'm pretty sure when a female in pregnancy, collapses, there's certain drills. Every hospital has a protocol. But if the physician who's been treating her, if he or she can prove it with a reasonable confidence that they have been sticking to the protocol that has worked for a lot of patients, I think the court will say in favor of the physician because these are circumstances that are not accepted. I mean, expected. So, the death is unfortunately a sad thing. I'm pretty sure the court will definitely sympathize with the cause of the petitioner. But as long as the physician has not done something grossly wrong, in or has there been any sort of negligence as the patient or the petitioner claims, I think it's then that the doctor will be penalized. But sticking to a protocol that has worked, that has been advised on a national level, and still the patient slipped out of hands, maybe it was not their day, I think.
One other thing that I think about here is it says deep nursing home, right? Um, when you talk about smaller facilities and like a tertiary center, do you think the same sort of the case would have gone this far if it was a tertiary center?
Can I
Yes.
don't think so that it would have gone that way because it's like the outcome depends on if all the reasonable things in case of emergency like were available, then we could have saved a life. This hospital, this nursing home lags here. There were chances if there were chances if they were having all facilities. If it was a tertiary care center, then a life could have been saved, or either they could have done a minor procedure or a intervention so that they could take the women to a higher center or a district hospital, because tertiary levels have that kind of facility that they could give a patient 1 to 2 hour ka buffer time, that we could be able to refer her to a more better hospital. This is what I think.
Thank you, Kushi. We have Boris in the meeting with us, and you've raised your hand, so please go ahead.
Yeah, I would like to add on to the discussion about this. Again, I'm seeing the case for the first time, just for the other members of the audience. Okay, so uh, what I feel in this is I agree with what Khushi said. And when it comes to these levels of care facilities, healthcare facilities, like starting literally from primary health centers to tertiary health centers to apex tertiary centers, like the whole hierarchy of it, it really depends on whether the patients or and the family were informed or were counseled about the possibility of such complications which come with any pregnancy. Of course, again, the additional discussion to this, or an aspect or perspective to this, is whether there is a um, reasonable doubt or reasonable clinical judgment for a complication to happen, and only then it's understood as it should be counseled. But regardless, for any smaller healthcare facility, they are supposed to counsel the patients about the facilities they have, and it needs to be considered while like in this judgment or in this court of law, that whether the patient and the family were informed about what all what all investigations, what all facilities, what all they have, and when, if at all, was reference done, and whether all of this, like literally from counseling the patients and the families about the facilities and even the referral part, etc., or whether all of it was documented or not. Because like one thing I remember, one of the lawyers tell me beautifully, like in one of the older sessions I had attended, that if something is not written, if something is not documented, that never happened. So when you counsel and document that, and when you like, or when about, even about the facilities, and even about the referral, that really helps for the physicians, for the doctors to safeguard, or the hospital systems to safeguard themselves against these situations. Again, I agree that it's sad and it's difficult for the family, but like going from a neutral perspective, neutral, like the court of law, I think these all safeguards would help us. And ultimately, when from what I know, when there is a maternal mortality, especially of unknown, or like or when the cause of that is not sure, like that is, the husband is alleging it is because of complications of like delayed care following a postpartum hemorrhage, versus the doctor is um, saying that it is because of an amniotic fluid embolism. So in such cases, or actually in most of the maternal mortality cases, an autopsy is done with the pathologists and forensic medicine specialists. So that would give an additional, that might give an additional clue, like be it a radiological autopsy or actual, like the autopsy what we talk of. So I think this, like these are my thoughts on like how what all factors would go into making a judgment in this case.
Thank you for that, Boris. Uh, does anybody have any other questions or thoughts? One thing that in this as well, when he spoke about counseling, and also initially when we had spoken about counseling, just to sort of bring that back, we could discuss it further in the subsequent days as well, about who does the counseling. Because I think one of us had, I forget who, but we had mentioned having specific people that are only for the counseling, so that the burden doesn't really fall on the doctors. But also in cases like this, do we think that we could build a system where a dedicated counselor could sort of cover everything, and we could maybe end up in a situation which is not this?
I think that would be the best thing to do. Because it will also reduce, or maybe end that thing that patients, end up beating a doctor, and that will, if somebody will be a mediator, it will be very easier for a doctor and for the patient to receive the grief. So I think it will be the best thing to do.
Correct. I also like agree with what you said. Now doctor being in the field of medicine, it's not a one man show. Expecting the doctor to do everything, I think it's a bit tedious thing to do. A lot of hospitals abroad and even private hospitals here have grief counselors and counselors who just make the job much more easier. So I totally agree with your point.
I believe that counseling should be the job of the doctor only, because as we are the one catering to the needs, to the healthcare needs, uh, the patient would love to hear from us only. I think adding a middleman will only make the patient distrust the doctor, that the doctor is not able to express his feeling, his or her feeling. Therefore, he needs a voice, a loudspeaker for their someone like that. So I think we should, instead of hiring and evading the responsibilities of a doctor, it's my personal view that we should be the one getting more sensitized and accepting our role. We are considered to be doctors. Doctors are considered to be the gods, even though we are beaten up. That's a separate issue. But people consider us God because we are the one who are able to deliver the news. We are able to communicate with them. They would feel much more satisfied and counts when we tell them more about our, by our own self, not by media. I believe this. But because see, the issue of violence against doctors is something which would drive this conversation off track. But we are Indians. Indians, whomever we pray, we disrespect, whether it be the rivers, whether it be the doctor. So Bhagwan na ban ke most let us make a wo we have develop an understanding between the patient that we are also humans and we are bound to do mistakes even though we are trying our best not to. So it would be much better if it comes from us. We have introduced the counseling, the ICTC in the HIV AIDS wala concept mein to chalta hi hai. But I believe that it should be us, the doctors themselves, who should be well educated on what they are going to do and how are they going to present themselves.
Okay, I believe this one has led to a lot of opinions. I see four people's hands raised. Porus raised his hand first, so you may go, and then we can go after that.
Yeah, I won't take a lot of time in this, but I
Yeah.
just want to add the concept which is quintessential to this discussion about clinical counseling versus psychological counseling. Like when I mentioned counseling earlier, I meant more so about clinical counseling, about the various aspect of the clinical care that a patient is getting, about what their prognosis is, what are the treatment options, etc., etc. That would come in clinical counseling, and that necessarily has to be done, I feel, by the doctors involved in the care. And when I say doctors, it means I would mean that in a multidisciplinary approach. Like, for example, if a person is going for a pregnant person is going for C-section, then that counseling should be a multidisciplinary counseling from the obstetrician, also from the anesthesiologist also. Um, etc. And whereas compared that to what one of the attendees spoke about is grief counseling, about that goes like that also involves a little clinical aspect, but that goes more into the psychological counseling when it comes to it, because grief counselors, if you all know, in countries abroad and even in India, when it comes to organ donation, they are not medical doctors, but they are either psychologists or social workers. And hence it's important to differentiate this two. But now this is one aspect. Okay. What I feel is, in such a case, coming back, like circling back to this particular case, after the death of the pregnant person, I think it would help to have what do you say? It will help to have multiple levels of counseling and discussion with the family, wherein the doctor also speaks and gives the opportunity for to the relatives and the husband to ask questions and understand the nature of the disease and what happened, as well as grief counselors if available. However, this is all a should, or like quote unquote should, or quote unquote ideal scenarios that we are talking about. But like as we know, in India there are a lot of social, like anywhere in the world, but more so in India, since we're discussing, the social determinants of health play a very important role. And when I say social determinants, also the part of economics also play a role, because when I'm assuming by the name of the institute that it is deep nursing home, so it might have been a private institution. And when a private institution is providing any XYZ facility, like for like, because grief counseling is itself a facility if you look at it objectively, right? So if they were to hire even a part-time grief counselor or whatsoever, it would come with additional cost to the hospital or the nursing home, which would translate to additional cost to the patient. And that is a gamble, not gamble, but what do you say, trade of that patients are usually not willing to pay, um like because they want healthcare somehow to be in the least possible cost. So that is something we could think of in an intersectional fashion, that it may not be always possible to hire grief counselors, etc. So it is kind of essential for medical doctors also, if they're willing to take that due risk of counseling, to learn that those counseling skills when it comes to the patient, because ultimately the doctors or the administration of that particular nursing home would be liable, right? Ultimately, like as they were sued and taken to the courts. So how much they are willing to put economically into all those, how much they are willing to take the burden of that on themselves, how much they're ready to or like basically, if they're hiring, whether they want to spend without the patients being affected economically, or whether they want to put that on the patients, or if they don't want to hire at all, whether they are ready to develop the skills. All these factors come into play, I feel, when such cases arise. That's all I wanted to say. Yeah.
Thank you for sharing. Uh, we had another person raise their hand, right? Do you have anything to say? Or we could wrap it up.
Oh, actually, it was a wonderful, summarization. I would just like to
Yes.
add like one little thing. What he said is true. Everything comes with a certain cost, but India is also a country where if you ask for 1,000, you'll get 10, right? So maybe asking for a grief counselor might be like too much. If it's off the park, but at least we'll get a separate room for counseling. And a lot of developing countries, yes, doctors do have to take multiple roles. So I might slightly disagree with Aditya, right? I'm not saying that, okay, I'll write a prescription and be like, okay, go now talk to him. That's not what I meant. So we also have a role, like what Paras said, like there is a difference between clinical and like psychological. Uh, Humanly, yes, sitting in a Zoom, like a chat, Google Meet or a chat room, and saying that okay, it's possible. We should also do that. Is I think it's a bit far-fetched. You being there, you're beaten up, you're being battered, going into a mob, knowing that you'll be beaten up, and be like, okay, I'm a doctor, I should counsel. I think it won't be practical. A lot of hospitals nowadays, government themselves are having counselors. So I've especially went to a medical college in Tamil Nadu. I'd like to name it Stanley. There they had a counselor who's counseled almost 200 people to donate. And he shared the story where he was able to convince a 2-day old, baby to donate. And that turned out to be the youngest transplant in Tamil Nadu, like youngest voluntary donor. So he just shared that. And so people are ready to talk to counselors. It's not that they are, it's wrong on our part to assume that, okay, we are the authority, they would like to talk. No, when we are not there, they're actually more close to patients. Sometimes nurses get more insight than doctors. White coat also comes with fear. Sometimes people just don't open their mouth to doctors. They talk to people who are not in power. So asking for a grief counselor, is it a far-fetched thing? Yes, but only if we ask for that, we'll at least get a room, a silent corner in the room for counseling. So being idealistic, being hyper idealistic in India, I think that is the need of the hour. At least then we'll get something practical. We have to keep pushing, otherwise we won't get anything. It's my thought. Thank you.
I agree. I agree. I agree 100%. Um, so, Divya, could you take over?
Yes, Karuna. So, as we bring today's workshop to a close, it is evident that navigating ethical and medico-legal dilemmas in reproductive healthcare requires not only knowledge but also the compassion and the sound judgment. So, on behalf of SIMSOG, we extend our heartfelt appreciation to our distinguished speakers for their time, expertise, and thoughtful guidance throughout the sessions. And also, our sincere thanks to every participant for engaging so meaningfully in the case discussions and helping create a space of shared learning and reflection. We truly hope that this workshop has encouraged you to approach with the patient care with a greater ethical awareness, sensitivity, and confidence. So, thank you once again for being a part of what went wrong, and we look forward to continued participation to future SIMSOG initiatives. We'll forward the we'll post the post feedback session forms now. So kindly fill this up.